try not to ramble. I go on tangents sometimes and I kind of go off slide. So I'm going to try to reel back in and go through some of the more basic parts a little bit faster, but stop me if you have any questions. And I'll try to answer them real quick. If it's like a lengthier thing, then maybe we'll have to talk about it, all the way at the end. But, we're flexible. We'll work on it. I got my master's degree in health and wellness. I focused on maternal health and lactation, and I wrote my master's thesis on tongue ties and their diagnostic criteria and the disagreement within the field on that criteria and on treatment and the impacts that has on individuals and family dynamics and society at large. I'm currently, here we go. Yeah, so I spent 2 years doing it. I finished in November of last year. So it's all up to date on evidence up through last August. There's been a bunch more evidence since then, and I'm incorporating that into my doctoral dissertation. So I'll sort of pick up where I left off and continue forward with that. I work pretty closely with Dr. Larry Kotlow, who is sort of like the grandfather of this whole field. He opened his practice in like 1974. He's been doing this for a million years. But I also, his sort of nemesis in the tongue-tied world is Allison Hazelbaker, who's an IBCLC, who treats tongue ties and is a craniosacral therapist, and she and Larry disagree vehemently on diagnostic criteria. They each wrote their own and treatment techniques, and I studied directly under her for about 1.5 years in my program. I took Larry's advice and did not tell her I was writing my thesis on tongue ties. So once she turned in my final grade, we sat down and had a glass of wine, and I was like, "Can I tell you all about this now?" Mm-hmm. And she doesn't talk to me anymore. Oh, because the end of my thesis basically was like, neither one of their diagnostic criteria is all that good, mm-hmm. and we need something better than what each of them are doing. So she was understandably grumpy about that. I founded the Breastfeeding Support Center, Western New York, in 2017. My office is in the Lower Elmwood Village, and I am a founding member of the International Consortium of Oral Angular Frenula Professionals. And it took me a good 1.5 months of practicing to be able to say it without stuttering. But it's amazing, and if anybody wants to join because you want to super geek out, the next major international conference of all of these researchers is coming up in Vancouver next October, and the whole point of it is to streamline best practice among people worldwide for this stuff, which is really exciting. It's also fun to hang out with the people who are doing all this research. So starting super basic, this baby was actually a client of mine, and his pediatrician said that there's no tie present at all. And they just sent that mom straight to GI. And they were talking G-tube because he couldn't eat. But this is really common, really common. I don't know if it's especially out here or if it's just that this is the bulk of my experience, but things are pretty rough out there for families with ties. What is agreed upon is that the frenum, which is that band of tissue under the tongue, inhibits full functional movement of the tongue. It's too short to allow for full range of motion. People understand that it can interrupt breastfeeding, but there's still some people that think that that's a made-up thing. But people generally agree, especially dentists agree, that optimal oral function encourages optimal oral facial growth and development. So I'm not going to belabor that point too much, though, because that's a lot of where Julia's going to go. What remains controversial still is a lot of people, especially local providers who are doing frenotomies, will say they don't believe in posterior tongue tie, like it's religion or something. They'll say they don't believe in lip ties or buccal ties, it's cheek ties, which is interesting to me. But so there's still a lot of controversy about all these things. There's no universally agreed upon diagnostic criteria. There's no universally agreed upon method of revision. So you can't say officially and go after anybody for not diagnosing or for mistreating, misrevising a tie, because the evidence is so wonky, you can't prove that they are doing anything that's amiss. So that creates some trouble, some problems for babies and families. I thought this was important to note, and this is information that I really find to be lacking in any discussion about TOTs, is that of all the information that is out there, and there is a plethora of it, but the problem lies in the fact that it's in so many different professions that you don't have the lactation consultant reading pediatric dentistry journals. You don't have a speech and language pathologist reading craniosacral therapy. I don't think they don't even have journals. They don't read the chiropractic journals anyway. But this information is everywhere. There's gastroenterology, otolaryngology, and nobody's talking to one another or looking at the whole picture. Everybody's got their blinders on. There are lots of people who are doing this training who are very much spouting that everybody needs to stay in their lane. But I think what they're missing is that the Venn diagram has lots of crossover between professions, and that really I think the best way that we can work together and help families is by tag teaming when it's appropriate. And people don't like to do that. I think that because they've had those blinders on, they don't have any idea what that whole puzzle is supposed to look like, so they don't know how their piece fits into it. And without having that bigger picture and understanding your piece, how are you supposed to work with other people? When other people are coming to you and saying, I want to work with you with this family, they're like, what are you talking about? So that causes problems. Families also receive very conflicting information and very frequently just end up being gaslit by their providers. When they're coming in, they're like, I don't know, everybody says the latch looks great. I've been told I have a low supply. I'm trying to breastfeed my baby. There's something wrong with me. And then she's going to carry that throughout the rest of her life, really, that she was this failure and she was inadequate. And I think that's really, really mean to do to people when really the answer is you just are ignorant. You never learned this information in the first place, but you've sort of figured out this thing in your mind, what you think is probably true, and then just say that it's factually true to people who are really vulnerable. So I don't think that's okay. And as a result of that, these babies go completely without treatment, and this can cause all sorts of problems for them, such as breast and bottle feeding challenges. The first formula feeding baby that I had in my practice took an hour to drink a bottle at 10 months old, and was clicking, and it had 2 older siblings with G-tubes. They were all tongue-tied. But there's nobody out here who can identify this, so this is something that happens a lot locally. You could have reflux symptoms and be put on reflux medication that won't do any good and does more harm. There can be postural deficits due to trying to protect the airway, so as people grow and have that forward head posture or some kind of restriction, it can just mess up the way that they're standing, which can cause other issues down the road. Disordered sleep breathing causes all sorts of stuff. Dr. Kagan will go into that. Systemic hypertension, impaired development of the face, oral and sinus cavities, malocclusion, which is crooked teeth, and all of the risks for women and babies associated with not breastfeeding. They're not benefits of breastfeeding, that's the biological norm. That's what humans are supposed to get those protections. And problems happen when we don't have those protections. And jaw issues can come along with that as well. Socially, I think very few people recognize social impacts of these things. ADHD is really, really commonly associated with all of this. There's an increased risk of special ed needs for kids that have sleep issues, behavioral challenges, speech difficulties. And the fun one to talk about with parents of babies is your baby may grow up to be a person who has a really hard time kissing or performing oral sex on somebody. And this is a major social impact. You should be able to do whatever you want to do with your mouth and be able to do it functionally. And there could be some really important social impacts of not being able to do that. I had a friend in high school who broke his frenum while he was making out with his girlfriend and bled in her mouth. And he's still that guy. 25 years later, everybody's still picking on him about it. And it's a little bit funny, but it's not okay. It would have been better for him to have been treated. Psychologically, this is another one that's even less frequently talked about. It's really widely known and accepted that failed breastfeeding and people who want to breastfeed is a really high contributor to perinatal mental health issues. But in New York State, the most recent data is that something like 87% of women start off trying to breastfeed their babies, and then by the end of 6 months, only 16.7% still are.
Wow.
So there's a really big problem in competent support available for people. And my personal anecdotal opinion about it, based on what I've seen, is that this is a huge contributor to that. And PPD also increases the likelihood of child maltreatment. Once that family dynamic gets off on the wrong foot, and mothers are being gaslit left and right by their providers, and now there's even been buzz about women calling to try and reach out and get mental health support, who are then getting their children taken from them before they even get the support. So it really is quite a quandary for families to try and succeed this way. And if you want to do better in the situation, you have to just keep your mouth shut and give your baby formula and call it a day, and then carry your demons for the rest of your life. I don't think that's okay. So there are a whole bunch of different treatments that people need, babies need, grown-ups need, everybody needs, for tongue tie, or when they have tongue tie. But the way that support looks depends on what the situation is, how old the person is. Everybody is going to need some kind of a revision at some point of the frenum to incise it in whatever way it's going to be split to allow for the full functional movement. But before that happens, people need to get functional tongue movement going. So there's orofunctional therapy, which is sort of like physical therapy for the mouth to teach the tongue what to do properly. And I do this as an IBCLC with my babies. With anybody who is too old to be in my scope, they need to have somebody who works independently or has the training to do it for older children, because it's going to look very different depending on who you are. Sometimes it's speech and language pathologists will get this, sometimes it's dental hygienists. I think very few people do it as a standalone profession, but that's still a thing. Craniosacral therapy, I require every single one of my clients to get craniosacral therapy. And I think we're going to get into a little bit more of fascia restriction and stuff like that later. That's a whole talk in and of itself. Craniosacral therapy sort of is to the skull and the head and the face and the muscles and the fascia what chiropractic is to the spine and the muscles back there. It's a similar level of knowledge and treatment ability, but in just a different part of the body. Really, really, really important. Lactation support, I'm biased, but we're the only providers who are treating both the baby and the mother. So while we're sorting through and dealing with the baby's issues with suck and swallow, I'm also managing that mother's milk supply and playing the long game to preserve breastfeeding however possible. If the baby can't latch, can't suck, can't move their tongue at all, we need to get them into craniosacral therapy ASAP so that they can get some work done before the revision. And then hopefully after the revision, they'll have enough functional movement that we can get that baby breastfeeding a little bit better, and then work over time to increase the oral function to get them to be able to transfer milk. So my scope of practice pretty much ends about 4 or 5 years old. I can't really justify going much further than that unless they're breastfeeding, but very few children are still breastfeeding at that age. So at that point, there's that Venn diagram crossover where sometimes speech and language pathologists or my functional therapists who are dental hygienists too can sort of come in and sometimes they deal with babies, but more or less it's toddlers on up. So I'm always happy to tag team with people, but there aren't too many people who like tag teaming. And obviously a major limitation is the availability of people who know about this stuff and know what they're doing. And finances are a huge limitation because this can all get very, very expensive, and a significant chunk of it is not covered by insurance. And there are some of us who are working to try and fix that. but we haven't quite gotten there yet. So I think one of the reasons that people have a hard time wrapping their head around ways that this can impact breastfeeding is that it depends on the mother too, and how her body is interacting with things. I have a lot of clients where I tell them, I'm really severely tied and I have issues, but I was that 20-pound, 3-month-old baby and I nursed till I was 3.5. And like, I'm okay.
Are you talking about yourself?
Yeah, I'm a functional adult, but I have a lot of issues that are related to it and have had surgeries that might have been prevented and things like that. So we have a really frank discussion about, do you need to do this now, or can you wait, or what have you, based on the situation. But I think that generally speaking, if a baby gains a lot of weight and the mom's not in pain, everyone's like, it's fine. But those moms actually end up with some pretty severe problems, where those are the mothers that get chronic clogged ducts, they get mastitis a lot. The baby can cough and sputter and choke during the nursing session because they don't have the function to manage her letdown. A lot of moms, the baby comes off and their milk's just spraying out, and so that can be a big problem if the baby can't manage it. They'll often get diagnosed with reflux and given medication that there's actually some recent evidence was just published, I think in USA Today or something, about how there's an increased risk of bone fractures among babies who are given these antacids in infancy. And we all know that can mess up digestion too. You really need the pH in your stomach to be right if you're going to absorb your nutrients and keep a happy gut. Preferential sleep positioning is a thing. Those are the babies that won't sleep on their back. They'll, snore and do all sorts of things, or just be really fussy about the way that they're going to sleep. So those are their moms that are trying to sleep in a recliner with the baby all night, so the baby's upright, and that's not a safe sleeping arrangement. I'm pro safe bed sharing. I'm not pro co-sleeping in a recliner on a couch. We know that to be pretty dangerous. These babies also can have really extreme weight gain. I met a baby last week at an expo that gained 2 pounds in a week.
Oh, goodness.
As like a 2-week-old baby, and it was like,
Wow.
like trying to control my facial expressions so this mom doesn't have a heart attack. That's that sort of inability to manage the flow scares me for that baby, and I know that baby's got a lot of problems, but everyone's like, oh, that's great, look at your fat baby, that's awesome. And it's hard to be the dissenting opinion in there, and like the total killjoy. What else do we have? Waking up congested after sleep. That can be associated with reflux types of issues. And there's a lot of challenges negotiating the suck, swallow, breathe response with these babies, especially when mom has a really abundant milk flow. But on the other side, if they have more of a typical supply, then babies will often very quickly get flow preference to bottles, often before they even leave the hospital. As of, I think, 2016, New York State had the highest rate of formula supplementation prior to 2 days of age than any other state in the country. So a baby who's got compromised ability to suck and swallow is going to very, very quickly prefer the ease of flow of bottles and refuse the rest very quickly. Sometimes after just 1 bottle, which they're getting in the hospital. They can get very, very fussy at the breast and fall asleep very quickly. Usually one precedes the other. And then during or after nursing, there's often this quiver, which I believe is due to muscle fatigue, because they're trying to do this wave, and we'll see a video in a minute, with their tongue, and when you physically have tissue preventing what you're trying to do, then it causes a lot of muscle strain. Even if initial weight gain was good, and I often get people into my practice once their baby is closer to 2 months old, where weight gain was great and she wasn't in pain, and everyone's like, yay, this is wonderful, and then suddenly there's a plateau and nobody knows why. And most pediatricians are like, good formula, it's fine, you're going back to work anyway, so just do that. But this frequently has more to do with the hormone shift in the mother from making milk based on the fact that she just had a baby versus the demand-based supply that happens after a couple of months. And then, that's what we call secondary low milk supply. But women are usually not told that it's secondary, because if you want to talk about the root cause of an issue, then you're just a crazy holistic person, and people don't want to talk to you anymore. So as part of my master's thesis, I did 2 different research projects. The first one I thought seemed like a great idea. I was going to take Dr. Hazelbaker's criteria and Dr. Kotlow's criteria and have multiple birth providers screening babies with each of these criteria to see whether there was any difference in breastfeeding success afterwards. Every single one of them got exactly the same one-on-one training with me about, like, this is exactly what the criteria is, this is what this means, this is what this means. But as it turned out, every single one of them scored it totally differently.
Wow.
And I had to scrap the whole thing because they were just, the data was all over the place, had nothing to do with anything. It was just completely impossible to determine what was going on. And there were a lot of referrals to local revision providers who I know to not perform complete revisions too. So I think I didn't realize all of the other variables that were involved that would skew that. So my next project that I did was to survey providers, and I was able to get a statistically significant number of responses. Anybody within whose scope it was to assess and diagnose and treat tongue ties was invited to respond. So there were people from all over, speech and language pathologists, chiropractors, dental hygienists, pediatric dentists, the whole 9 yards, IBCLCs. I had obstetric PAs and obstetricians, and what happened was that I didn't actually get into all the findings here, but fewer than 2% of respondents could answer any evidence-based questions about ties and about the ways that ties impact the body. And something like 20% of them were assessing, treating, and diagnosing ties without ever having a single in-service or education opportunity about this. So we have a really big problem with lack of evidence-based care available and lack of any streamlining for this. So the disagreement among all of these professionals has just not ever been explored in the literature in the first place, and in my opinion, that's one of the biggest hurdles that we have to overcome, that nobody's even started having this discussion yet. The definition of evidence-based practice is that as you gain new evidence, you change your practice according with that. But we have lots of people who've been practicing for 20, 30 years doing the same thing the entire time. For a fact they're not reading about this stuff. But also, even if they wanted to, it's very difficult to access all of those journal articles. The journals are very expensive. Unless you have access to an academic library, it's very difficult to get this kind of information. So it's not that they're bad, awful people, it's that there are lots of structures in place to prevent them from getting this information. This is a really unique aspect of treating a person. And it definitely helps explain the high levels of failed breastfeeding, disordered sleep breathing, and organ functional disorders. And provides a really good theoretical understanding that's never been explored about postpartum depression and anxiety rates, which are pretty astronomical. Of the people, I think 80% of my respondents had received some kind of training in tongue tie, mostly from either Dr. Hazelbaker or Dr. Kotlow, but only 2% could answer evidence-based questions. So the education training people are getting is not that great of quality. You can be very, very smart and not be an excellent teacher. There's a lot of different factors involved, but a lot of this too can be very difficult to generalize unless you're working with this population every day. And just reiterating physical, social, and psychological issues that come along with misdiagnoses. All of these physical and emotional maladies that happen as a result of failed breastfeeding are completely preventable. There's been very little exploration of the fact that their breastfeeding rates drop off so quickly, and I think we need a lot more research on that. All right, cool. So this is kind of a quickie. I show this to all my parents. Beautiful.
Breastfeeding.
Okay. So for those who don't know what they're looking at, this is the roof of the mouth here. Front of the face is that way.
Although looking at an ultrasound video.
That's the tongue, and this is the nibble inside the baby's mouth. So that tongue does this
Note that the tongue moves not only.
in order to get the milk back. But when it's tethered, this part of the tongue can't elevate up towards the roof of the mouth. So this is the posterior portion of the tongue. It's like the
Anterior
mid-tongue.
tongue tie constricts the tongue.
So the anterior tie is the only kind that's commonly recognized around here, which is where the frenum comes all the way to the tip of the tongue, like that first baby, although sometimes they're missed. But the posterior portion is always behind an anterior portion. There's no one without the other, really. If the tongue can't move and elevate up to the roof of the mouth, then it's a tie. It doesn't matter, in my opinion, what grade it is, what severity it is. Either it's tied or it's not tied. And see how they're using their tongue while they're nursing. So this is the party trick that I teach moms. Like at 4 o'clock in the morning when you're not sure what's going on, look at this. I'll have moms send me videos of just this so that we can follow that baby's improvement over time.
Just get the revision with no, like, what if that's not the protocol?
Very frequently, they do. And depending on the nature of the way their anatomy is, some babies will be fine.
Yeah,
And other babies just have worsening symptoms.
Even after the revision?
Yeah.
I didn't take
Yeah.
Spencer for any therapies. We just went to Dr. Cotlow, got him.
Is Dr. Cotlow local?
No, he's in Albany.
Oh, okay.
That's a fun drive with a 2-month-old.
Oh my
Because
gosh.
I didn't reach out to Mary. He had a really bad lip tie, my son, who's a year and a half now. And Dr. Cotlow and you both, I think Dr. Cotlow thought his tongue was worse than you did. I didn't think his tongue was that bad.
That's because Larry added half sizes into his criteria without telling anybody. I was like, Larry, you can't do this to me.
So we drove. I didn't notice his tongue or his lip was so tight his lip wouldn't flange up when he nursed.
Okay.
It would roll under his gums, and he was like 2 months old before he even thought to reach out to ask about a tie. And we went and had him corrected, and he is absolutely 17 months old and still nurses, mostly to sleep. He still nurses. And he's
So
wonderful
lip
now.
ties can be upper and lower or lower?
Yep. Yeah, but lower lip ties I think are pretty unusual.
Okay.
They're not very well documented
I
anywhere.
just wondered. Yeah.
I haven't ever seen one personally, but I know that they do exist.
So that's one of
I'm
the
not
things,
the
if
be-all,
a baby,
end-all.
if you go and you're helping a mom and that latch and they're not rolling up, flanging out.
Well, they don't have to go all the way up fish lips. They can just
Right.
be averted like kissing,
Yeah.
where you can't totally see it. You don't want them tucked.
No, I
he tucked
understand that. So
every
they're-
time.
Oh,
Every
yeah.
time.
Yeah.
He'd latch on, he
Um,
tucked his lip under.
And those are the babies that are leaking milk out the corner of their mouth
Mhm.
because they can't make a seal at the breast and stuff like that. So no.
Yeah,
going
but we never
backwards
went for
again.
any of the therapy, and he's great.
Everything's working beautifully now.
Mhm.
So the general treatment process, and I think we're getting close here on time, is that they'll come and they'll see the IBCLC first, who knows about this stuff and knows the whole habilitative process and all of that. There was not a single question on the IBCLC exam about ties, not one. And
And the
there's
6-hour exam, no questions.
not one, nope. And
Is that
the
something that's being
information
worked
in the study guides, for those who are studying the exam, is technically correct based on some data, but there's plenty that conflicts that as well.
Goodness.
So it's not just like you go to an IBCLC and they know what they're doing, and it's not because they're not good at their jobs, and it's not because they don't care, it's because it's really hard to get the good information. So finding the people who know what they're doing is really important when it comes to this stuff. And I usually end up getting people after they've seen several other IBCLCs who couldn't resolve their issues, and then they come to me as a last ditch effort. And they're almost always tied by the time they come to me. That sort of qualifies my clientele a little bit. I recommend a minimum of 2 to 4 craniosacral therapy appointments before the revision happens, depending on how things are looking in there. Some babies, I can't even get my fingers under their tongue to look and see really how bad is it. Those babies need a little bit more work. If there's somebody who's on the fence where I'm not totally sure whether they need a revision or not, but there's definitely a restriction, those babies I'll tend to have in doing craniosacral therapy for a little bit longer period of time to see maybe there's another issue due to like fetal positioning or whatever that may be causing that restriction, because it could be muscular and not actually the frenum itself, but it may look like it. Alison Hazelbaker calls that a faux tie.
Okay, so some babies respond just to the therapy and don't have to get the actual.
Most babies will show improvement before the revision,
Okay.
just after that therapy, because they get some better functional
Mm-hmm.
movement. The connective tissue that holds the muscles together gets very, very tight, so when you loosen that up, you have some better movement, but you might not be able to have full range of motion yet.
Right.
And with each adjustment, it's kind of like a baby coming out of the vagina. They come out and then they go back, and then they go out a little more, and then they go back.
So you do
So you need to
babies
have-
for babies coming out.
Right. You know, so you need to have those appointments over a period of time so that all of that musculature can move appropriately. So the revision itself happens after that. The closest provider that I recommend for infants is in Ithaca. We have somebody in Syracuse, and then there's Albany, and that's it for all of upstate New York.
So what if a person's in a different state? How do you check those people out?
Through Facebook, really, it's just word of mouth.
Mhm.
You know, the International Consortium of Oral and Frenulum Professionals, we all talk a lot,
Mm-hmm.
and there's really frequently like, oh, do we have a provider who's out this way? You know, so we can try to find people who have been trained adequately, because we don't want to send people to somebody who doesn't know what they're doing and only cuts the anterior portion of the tie, the front of the tie, and leaves the back, which is what happens locally. So people will take care of the front of the tie, leave the back, and nobody's checking to see how well that baby can elevate.
You're having your conference in Canada, does that speak to how many providers are looking into this in Canada, or is that?
Oh, it's just because it's more centrally located. We've got a lot of people, obviously in the US and Canada, but then the bulk of the rest of our membership is actually in Australia and the Philippines. And then there's a handful in Israel. Israel's like this hotbed right now of Thai research, which is really, really
There's
cool.
actually a lot
population
of
of
research
Thai
coming out of Israel right now.
Yeah, it's awesome.
It's a very high.
Israel and Australia are like the biggest and the best, where things are a little bit more streamlined. There's a lot more egos clashing in the States. That's what we do best.
We're all ego.
So within 48 hours of the revision, I have people come back and see me because the method of follow-up wound care that they're recommended by the dentist that they see, in my opinion, is really bad for them and actually increases scar tissue formation. There's a lot of physically touching the wound site over and over again and stretching it up. And this can be really, really traumatic for babies, and I just have way too many babies that were growing very thick scar tissue very, very quickly. And when I was reaching out to Dr. Cotlow, and I was like, hey, what's going on with all these babies? This doesn't feel right to me. He's like, oh, the parents must not be doing the stretches right. I'm like, well, they are, because I can see what they're doing, and I know exactly how you teach them to do it, and they're doing it right. They're pretty invested in this. So then I found Jennifer Toe, who's an amazing teacher in all of this. She's been working this for 30 years, and I use her methods now, and since I switched to a more gentler form of elevations rather than stretches to manage the wound care along with a homeopathic protocol, it's night and day difference. The babies are calmer, scar tissue is virtually non-existent.
What do you do?
It's a big, long protocol.
Okay, I was gonna say, what's the difference between,
Yeah, it speeds up healing.
versus
Dramatically,
Because,
actually.
I did what he told me to do.
And for a lot of babies, that works.
Yeah.
But for something, it was something like 10 to 20% is the accepted reattachment rate for people who are using those methods. And I'm
Yeah.
like, that's way too many. Like,
Okay.
you know, 1 in 5 or 2 in 10, like, no, I'm not comfortable with that. And the rates are so much lower now. And we even have extra homeopathic remedies we even add in if the baby is starting to form scar tissue that can help to delay that and also speed healing. So they can just heal up really well very quickly before you have a chance to keep messing with the site. So healing is so much better now.
And what did you say the name of the protocol was, or the person who?
Oh, her name is
Jennifer?
Jennifer Toe. She does lots of really She's doing training in Rochester in a couple of weeks, I think, but I
Like
couldn't make it.
TOE?
TOW.
Okay.
Yeah, she's an IBCLC. She's a certified orofacial myologist, and she's been doing this for ages.
So these are something that my daughter should like ask what kind of rehabilitation, because she said there were exercises. She said they told me there were exercises we were supposed to do, but who knows?
Well, and there's a difference between exercises and stretches. You know, exercises aren't wound care. So there's a lot of questions that people don't have any idea that they should be asking, and it's not their fault. Most providers don't know them either.
So the exercises are once the healing is done. That's like the PT for
The exercises start beforehand. They start immediately from the day that I see them.
Okay.
And change over time. So after the revision happens, we change them and there's no more work under the tongue except for an elevation to help with wound management, because I'm not going to have them messing under that tongue. It's just really traumatic for everybody, and it's
Sure.
going to cause scar tissue formation. So I wait until healing happens. And the protocol that I use helps to speed that healing by 2 or 3 weeks faster. And then after that, we resume the under tongue exercises. So I tell people it's anywhere between 4 and 8 weeks following the revision before we have full functional movement, generally speaking. The younger they are, the faster it goes, because they have all of those great innate reflexes to fall back on. An older baby or a baby who's a year old or 18 months old has a lot of learned behaviors and
Wow.
compensations that we have to work through, and they don't have as strong instincts anymore. So that's when it gets more into like the oromyofunctional therapy stuff and the PT sorts of things. With infants, you don't need to do that as much. So then I have them follow up with me at 1 and 2 weeks post-revision so I can monitor healing and help address any issues if scar tissue is starting to form. It usually starts about a week post-op, but can continue for 4 to 6 weeks, depending on how well that baby's healing. I've seen babies who did great for the first 2 weeks, and then by 3 weeks they had this big nasty hunk of scar tissue, and that was after they got the all clear from the dentist to stop doing the stretches and stuff. So there's a lot to this that really hits a lot of people over the head because they're not expecting it to be this complicated. Yeah, so then after the revision sites are healed, then we can add some different exercises in. So this is what the revision looks like. This is the same type of laser that Dr. Codlow has, but Dr. Dyad in Ithaca, it looks the same, it's just a different type of laser that she uses. This is the nose, this is the upper lip, they're doing the lip tie. Wide open mouth is that baby screaming.
So they don't do any anesthesia?
No, when they're very, very young, the tissue's not very well vascularized yet. It doesn't have a lot of nerve endings. But if you numb it, then that baby can't nurse right away. You have to wait for the numbing to wear off, which just prolongs the upset. But I got to assist in a couple of revisions of infants, and honestly, they started screaming as soon as we held them still and opened their mouth. The scream didn't change when the laser started going. I think they were just really angry because babies like bodily autonomy. So it more or less just vaporizes the tissue, makes it go away. It's usually a fairly bloodless procedure, and now you can see how much higher that tongue can elevate in the mouth. The revision isn't complete until they have the ability for full functional movement. And then my job is to make sure that they can maintain that and have the muscle strength and coordination to continue that. There's an advertisement for light scalpel. Yeah, so there we go. That's the nutshell.
It's interesting that